Welcome, David Wiss here, dietitian, founder of Nutrition and Recovery. I'm here to present to you over quarantine. I'm sharing my latest slide deck, so this can be a webinar / video for someone that's looking for the latest information linking nutrition to behavioral and mental health. If you know someone that would benefit from this, please share it with them, encourage them to follow me, sign up for my newsletter, which you can do at nutritionandrecovery.com. A little bit about me. I'm from West Los Angeles. I went to public school. I have my undergrad in social science with an emphasis in economics. I did my master's degree in nutrition and did a thesis at the VA called Nutrition and Substance Abuse, which is kind of my lane. I did my dietetic internship at UCLA in the hospital. I did a rotation at the eating disorders unit, and I founded my private practice, Nutrition and Recovery, as soon as I became a dietitian. So that is a disclosure there. I'm the owner of a group practice in West LA. And 3 years ago, I decided to go back to school and get my PhD and been studying public health at UCLA since. So I'm a combination of a clinician and a researcher, and hopefully you'll get that from me today. Early in my career, I became part of a group. We co-founded Dietitians for Professional Integrity, which took a really strong point of view about issues around corporate sponsorship. This got me really excited because I wanted to make a real difference, and I knew that there was a conflict going on in my field. I knew that there was a war between public health and private profits. And as a group, we started to speak up against these things, and we made a big difference with respect to corporate sponsorship. And I'm really proud of the contributions we made. And we are going to talk a little bit about food politics today, but I'll tell you, it has changed the way that I understand nutrition because we're now thinking about economics and capitalism and some of these larger issues as opposed to just nutrients and biochemical stuff, which we're going to talk about as well. I do want to disclose that I have no particular way of eating. I don't have any agendas to convince anyone to eat a certain way. There's this question, should nutrition researchers have to disclose their preferences? So I kind of think so. If someone is doing specific research on a specific way of eating and they eat that way, there's a bias, right? So I'd like to think that I don't have any nutritional biases, perhaps identifying as a diet agnostic. The work that I do is grounded in the biopsychosocial model of health. This emerged in the late 70s. Essentially, it's a way to conceptualize health from the invisible subatomic level all the way to the tissues, to the nervous system, to the person, right? And then to the family, community, all the way up to the planetary level. It's controversial because it has been an effort to merge different disciplines, and some people don't like that. When you merge, biological sciences and social sciences, but it's the only way to look at things as a real system, and that's what we're going to talk about today, thinking in terms of systems. The biopsychosocial model has increased in the last 20 or so years, and this is just how many articles are indexed in Scopus. So you could see that it's rising, and for good reason. It has overlap with psychosomatic medicine, so there are other terms which are describing the general framework which we're using today. These are the domains of psychosomatic medicine. You could see here at the intersection of psychological, biological, behavioral, social, cultural, and economic, there's biopsychosocial. And because we're talking about addictive disorders, that's a big part of the biopsychosocial model of health. If anyone's ever worked in addiction treatment or been to addiction treatment, the intake process is actually called a biopsychosocial. I've made the argument that there isn't enough emphasis on the biology, and we're going to talk about that today. As I mentioned, people seem to get nervous when you start merging different disciplines. One of the things I've become interested in is what I like to call discipline bias, how people that are biomedical have a tendency to be very reductionistic and lack context in certain theories, whereas social scientists may poo-poo on some of the genetic research, etc. So there are certain areas that are clear overlap between psychological and sociological theories, like gender theory, for example, and there's some psychobiological research going on, but like I said, very rarely do you see all three disciplines being converged into one, which is what I'm basically hoping to do with you today. I also want to pay respect to Dr. Nancy Krieger, who has been a great influence on me. She's a social epidemiologist and really brought this term embodiment into the literature, describing how social factors can actually become embodied into the human experience, and there's a multi-causal way of thinking about health. So not just looking at someone's household, but also their environment, as well as considering maybe perhaps biomarkers as well. The work we're going to talk about today is grounded in the life course perspective, which is a broad way of thinking about health and human development. It looks at multiple pathways that can accumulate over time, essentially considering how early life exposures can affect later life health outcomes, and how certain things can be deleterious as well as be advantageous or protective. I'd like to say that being a UCLA Bruin, I stand on the shoulder of giants. There's been a lot of work that's come before me, and it's really important that I acknowledge work that's been done. The Risky Families model essentially looks at family social context as well as genetic factors and considers how risky environments can affect the stress response and the biology there, which can lead to other risky health behaviors and essentially to mental and physical health outcomes over the life course. A couple key terms. A theory, as you probably know, is a framework that should be testable. It's designed to understand, explain, and predict. It always comes with assumptions, and I think it's important to just state that we're going to talk different theories today, and I will do my best to describe what some of those assumptions are. The term modeling is also important. I learned in statistics that all models are wrong and some are useful. A model is an effort to define something. So in statistics, we'll build models in order to detect associations. That's at the population health level. Whereas we as individuals, we also are building models in our mind based on our previous experience. We want to be able to promote our survival and learn things that are threatening and things that can become easier. So for example, if someone is a nutrition counselor like I am, oftentimes people will have a food philosophy, and that is a form of a model. It's like a way of thinking about things so that you can put people into the model and be able to create some kind of output. Another term that I think is important is convergence. It looks at commonality between different theories and where they overlap, and then divergence, which is the opposite, where certain things may depart. The term dialectics is a key part of what we're going to discuss today. It's the art of investigating truths and varying opinions, essentially looking at opposing ideas and how to balance these opposites. I love sharing this and asking where people see either the white vase or the two human beings face to face. Usually people see the two people more often than the white vase, but I'm staring at this right now and I'm just seeing the white vase. The message here is simple. People do see things differently, and it depends on so many factors that are not always easily predictable. Causality describes the relationship between cause and effect, and the directionality looks at the property of something being directional or maintaining a direction, and this will make more sense as I present to you some of my more recent work. Okay, so what we're talking about today is nutrition for mental health in a broad sense. Historically, nutrition for mental health has looked at vitamin and mineral deficiencies, essential fatty acids. There was a big trend towards amino acid therapy, which I think is still happening in some areas. There's been themes, groups that have been run, food and mood. We've always known, you eat better, you feel better. Emotional eating's been popular, but here and now we know some new hot topics: food sensitivities, food allergies, gut health, microbiome, inflammation, oxidative stress, and we're going to talk about some of these things today. Looking at single nutrients is very reductionistic. So, for example, studying the effect of a single micronutrient deficiency on a mental health outcome, there's some, definite value there. However, I think we need to go much further. So in nutrition, we often talk about what to eat, but when we talk about nutrition for mental health, we're also thinking about our relationship to food, which goes way beyond nutrition. So we're going to think about how we eat and how we think about food. And so there's so much more to nutrition than just the what. When I do an intake, I ask people, what percentage of the day do you spend thinking about food and body, right? If someone spends 80% of the day thinking about food and body, that is a mental health situation. I've kind of said for many years that eating disorder training is outdated. There's definitely a need to get out of the box and bring in more recent data on physiology, the neuroimaging stuff, gut-brain access. These are things that have not been successfully integrated into current eating disorder treatment, and I see a great need for some of this new data. We know that dieting is a risk factor for eating disorders, and we know people fall into the cycle of dieting and restricting and binging and negative emotions, and it goes back again. But as a public health person, one of the things that I'm interested in is, where does all the dieting come from in the first place? In other words, what are some of the more upstream causal factors? My early work described nutrition therapy for co-occurring eating disorders and substance use disorders. This book essentially had the goal to encourage clinicians to do integrated treatment rather than sequential treatment for eating disorders and addictions. They've always been treated separately and sequentially, and now we're thinking about how do we treat them concurrently, and that's a big trend. I wrote another chapter in that book on eating disorders in the male population, which I've been able to do some important clinical work on. So my main area is substance use disorder and nutrition. I've been following the literature, which is not that robust, but I'll review some of it. We know that there's malnutrition. We know that intravenous drug users have food insecurity and food insufficiency. We know that there's a strong preference for sweets and a very low intake of fibrous fruits and vegetables. So we know that micronutrients are often low. We know that there's deficiencies in important antioxidant vitamins. We see iron deficiency anemia. We see elevated inflammatory markers, and we see antioxidant disturbance, which interestingly has been implicated in relapse. One study from Norway showed that individuals addicted to drugs ate a third of their food from added sugars, and most of them preferred sugar and sugar-sweetened foods. Now, eating disorders and substance use disorders have significant overlap. There's bidirectional relationships, and there's a lot of behavioral overlap, and this is something that I've become very interested in. The comorbidity between eating disorders and substance use disorders is somewhere between 3 and 50%. So that means, I don't know, maybe a quarter, a third, a half of people that are in treatment for one have an issue with the other. Subclinical eating disorder is pretty common. In people with substance use disorders. We're talking about things like night eating, dieting, body image issues, etc. The mainstay in eating disorder philosophy is what we call the transdiagnostic theory of eating disorders. It essentially proposes that the diagnosis is not relevant, and this was published prior to the DSM-5, where binge eating disorder became a standalone diagnosis. But I've started to think that this theory might be challengeable based on some of the recent data we have on food addiction, which we're going to talk about today. Intuitive eating is a really important model that is used not only for people with eating disorders, but for people that are engaging with diet culture, etc., have learned to distrust body wisdom. And the assumption in intuitive eating is that if we can move through the diet culture mentality, what we call the diet mentality, and move toward trust, then one will be able to successfully trust their hunger and fullness. And I would say that this is a good assumption if someone's gut is balanced, if there isn't an active addiction, if hormones are relatively stable, and if you give mindfulness training, yes, one can be in sync with their intuition. However, I'm of the belief system that if someone's gut is totally off, totally imbalanced, there's active addiction, hormonal extremes, and mindless eating, or more specifically, a history of trauma, then it will be very difficult to assume that someone will succeed with this. However, it can still be a good long-term goal and still be used, but I think that the assumption that everyone should be able to access this is certainly not true. One of my early works was on eating during pregnancy. We actually reviewed all of the animal data, which showed that maternal exposure to highly palatable foods, so high fat, high sugar diets, basically, Oreos and Doritos and things of that nature, could actually program the offspring to be more susceptible to addiction-like processes. So mice or rats that were born from mothers put on extreme diets not only had disordered and dysfunctional eating, they were more susceptible to drug addiction. So essentially, what a mother eats during pregnancy has the potential to program the neurodevelopment of the offspring. Another paper I published on sugar addiction was, collective work that we've done in both animal and human models, and essentially reviewed how other neurotransmitters other than dopamine, such as acetylcholine, is involved in the addiction process. What we did here was took the 11 criteria for substance use disorder and looked at the evidence that existed in the animal data, and was able to determine that most of the criteria can be met from experimental evidence that we have so far. Obviously, social impairment cannot be assessed in an animal model. And I know sugar addiction and food addiction are very controversial, and I've taken the position that this has more relevance for public health than it does for individual level interventions. We've created different theories with respect to food addiction. We know that diet culture or dietary restraint is a major driver of binge eating. Assuming food addiction is real, the diet drives the binge theory suggests that it's the dieting that drives the dysfunction, whereas the food environment drives addiction theory suggests that it's these highly palatable foods that are very accessible and very much inundated in our food environment that can drive addiction like eating independently of dietary restraint. So these are just different ways, different models, different theories, different conceptual approaches to think about this problem, and I think it differs at the individual level versus the population level. So we know that addictions are a growing social and economic burden. We are in the era of the opioid crises. With respect to nutrition, there's no standardized practice. There's no real guidelines. I've published some recently, which I'll share with you today, but there's definitely a trend towards, especially in the private sector, places wanting to include more holistic approaches. The Academy of Nutrition and Dietetics in 1990 published a position paper which urged dietitians to take aggressive action to ensure involvement in treatment and recovery programs. However, position papers are renewed every 5 years. This one was not renewed. There was very little progress incorporating dietitians into drug rehabs, possibly because RDNs are not interested, most likely because there's very little research, therefore there's very little insurance coverage and very little funding for new initiatives. So I'm really working to produce more data so that this can become a more widespread consideration. We know that in early recovery, people gain weight. We know that when people get sober, they often eat too much, so there's a lot of binging and emotional eating. A couple studies have shown that women are very much concerned about weight gain triggering relapse. In one study, 70% had weight-related concerns. So it gets really tricky. On one hand, if you don't address, body image and weight-related concerns, and it's an underlying etiological factor, then, you're missing something in treatment. On the other hand, if that is not done by someone who's eating disorder informed, you can actually, activate disorder and dysfunctional dieting, which can be a whole new problem in itself and lead to relapse. So there's an intersection here that needs to be addressed by trained clinical professionals. Doing research isn't as hard as it might think. A couple years ago, we did a rapid assessment by looking at all the treatment centers in Los Angeles and we had 128 that met our inclusion criteria. We actually had more, only 128 responded to our quick survey. We found that less than a third offered any nutrition services, and of those, most of them did not use dietitians, so they were using other nutritionists, counselors, etc. So dietitians are present at something around 7% of treatment centers in LA as of 2018. So we concluded that there are certainly some unmet needs. We have also published some work describing groups that could be useful in treatment settings. And I've since updated some of the curriculum and have made curriculum available on the website, and feel free to reach out to me about that. We do know that interventions in addiction treatment can be successful. We know that in the VA system, in the prison system, and at certain residential facilities, we've seen positive associations. The intervention data is not that strong. We need more trials. We need more cohort studies that actually show that this thing can make a difference. And I think one of the reasons why this research is so hard to do is because nutrition is slow. It doesn't happen in a week. It's something that happens over months and years and really happens over the life course. So it's difficult to measure the effect of a nutrition intervention at a 30-day interval per se. I've always been a big proponent of cooking classes and making that a mandatory part of treatment, developing life skills, helping people go grocery shopping and meal planning and kitchen cleaning, etc. This is a really important part of residential treatment, in my opinion, that is not being successfully implemented. We had a grant in Santa Cruz last year that brought me on to essentially revamp their food service operation at a couple different treatment centers. And we essentially had a three-pronged approach. We changed the overall menu, we brought in nutrition curriculum, and we brought in some hands-on culinary literacy groups. And when combined, this can actually be very effective if the nutrition education matches the food being served and people are learning how to make it. People do seem to get excited, and this work is really challenging, and it has to be supported all the way up through the entire organization to the upper management. As you probably know, the gut bacteria thing has changed the way we think about nutrition and mental health. I use this science a lot to educate people around the why this thing matters. We're not just eating for nutrients anymore. We're eating to alter the gut bacteria that live inside of us, and people seem to starting to understand that more and more. There's about 2 to 5 pounds of invisible microbes that live inside of our gut. People are calling it another organ, or you've probably heard the term second brain. The reason this has really blown up in recent years is because of the testing technology. There's been some funding initiatives and some really awesome ways to assess gut bacteria from stool samples, and it can be done relatively quickly. However, if you do a commercial kind of stool testing thing, it takes several weeks, and if you haven't done that, it's kind of fun. There's very little that you're going to learn from a single test, but you can follow it over time and see how certain things like fibers and probiotics can make a difference. We know certain functions about gut bacteria for quite some time: breaking down fibers, biosynthesizing vitamins and amino acids, etc. But recently we have new insights. Gut bacteria are involved in the development of a wide range of diseases, affect brain health, and where I've become really interested in is in learning and behavior. One of the major findings was that, roughly 90% of serotonin is produced in the gut, maybe about half of dopamine, and this was a big splash in the mental health field. It really strengthened the argument that what you eat matters and that we have to focus on gut health. I do like to make one quick point. There's a lot of other pathways other than neurotransmitter production, the vagus nerve, the HPA axis, inflammation. But the point I always feel like is important to make is that nutrition doesn't directly treat drug addiction. And I'm not saying that it does, but what I am saying is that nutrition has a profound effect on conditions that cluster and co-occur with drug addiction. So nutrition interventions can drastically improve one's levels of anxiety and depression over the course of several months, which can really spill into recovery from substance use disorder. I do think that changing the way we eat can also affect reward pathways, although there isn't data on that. Maybe I'll be the one to produce it. So with respect to anxiety and depression, we know that we want to get people on high quality diets. Okay, that means high in fiber, high in omega-3. Probiotics can be helpful, but again, when you're talking about things like high quality diets and you're dealing with people that are at risk for an eating disorder, you have to be careful about how this language is messaged, because you don't want people turning into orthorexics. You don't want people not being flexible with eating food that is served in an institution. So again, I'd like to emphasize that to really be a nutritionist for drug addiction, it does require an understanding of gut health, and it does require an understanding of eating disorders. What we know about alcohol in the gut has drastically changed in recent years. We know that ethanol alters the microbiome. We've kind of assumed certain things about alcoholic liver disease, okay? So traditionally, people thought alcohol, which is ethanol, travels to the liver and causes damage through acetaldehyde. But now we know that ethanol actually alters the gut in some ways that create disruptions in the tight junction and lead to bacterial translocation. So as you can see here, ethanol leads to dysbiosis, which is associated with inflammatory conditions. This can create that gut leakiness or intestinal permeability, and little microbial products or LPS, lipopolysaccharides, can leak into the blood, which ends up traveling through the portal vein to the liver, and this is how alcoholic liver disease occurs. So our understanding of the pathogenesis of certain conditions has changed, and this is true not only for medical conditions but also mental health conditions. So this is a really easy and fun way to understand intestinal permeability. Essentially what happens in a leaky gut situation is the mucosal barrier becomes compromised. Now there's a lot of things that can lead to this. One of the things that I'm interested in is a chronic low fiber diet. There is some evidence to suggest that if there isn't enough fiber, some of the microbes can start eating at the mucosal layer. Other things like medications and a bunch of other environmental toxins can compromise the gut. More recently, it's been shown that stress itself can lead to intestinal permeability, and this is all associated with low-grade systemic inflammation. And where I've become interested in is how do these inflammatory markers, cytokines, etc., how do they affect other organ systems, including brain health. In one study from our Belgian group, our friends showed that gut leakiness in those with alcohol use disorder correlates to depression as well as craving. And this was true even after they were sober. So at 3 weeks abstinent, those that had gut leakiness had persistent anxiety, depression, and craving. So it has been shown that even if someone's gut problems are linked to their alcohol or their drugs, those gut problems can stick around for a while and even present as what one might assess to be a psychiatric condition. So, hot topic, I'm following this very closely. It turns out that inflammation that occurs at the gut can accumulate and cross the blood-brain barrier. There is some evidence to suggest that inflammation can travel to parts of the brain, and this term neuroinflammation describes how a part of the brain like the amygdala, where we experience emotions like craving, anxiety, depression, can become inflamed. So very, very hot topic, more coming on that soon. So we know there's bidirectional communication between the gut and the brain. There's multiple pathways, and I don't have time to cover them all. I will say that there's probably more than we currently know, and it's constantly being elucidated. The vagus nerve is super interesting. It's It's the largest nerve in the autonomic nervous system that connects the back of the brainstem to multiple organs, and it's bidirectional and has some very interesting ways to communicate throughout the body. So in a nutshell, to make this really clear, a healthy gut is a wide range of bacterial species. So we want a diverse microbiota. And as the mucosal barrier becomes more permeable, maybe it's because of reduction in bacteria from poor diet or from alcohol, there's higher levels of inflammation, higher levels of oxidative stress, which takes someone to the red on the right side, which is low diversity, increased permeability, and low-grade systemic inflammation. And I think a lot more people are living in this kind of altered symbiotic state than we would imagine, and I hypothesize that this is linked to a lot of our current mental health issues. So if you think about all the different pathways between the gut and the brain, it's important to acknowledge that they're all nutrition related. They all have relations to what we eat, supplements, etc., medications. Anything that's happening at the gut can affect the brain. So this is making a really strong argument to prioritize nutrition in mental and behavioral health. So this is some more imagery to help you understand what's really going on. Again, these are just conceptual models based on our current understanding. Gut bacteria break down amino acids, convert them into neurotransmitters, and a host of other postbiotics, we'll call them, such as short-chain fatty acids. All of these things that are essentially, converted by bacteria, then pass through the gut lining, the intestinal barrier, and are sent to various organs. Now, this particular image is looking at peptides and amino acids. I am more interested in the role of dietary fiber and the breakdown of fiber by microbes and the production of postbiotics as well. And I think that there's going to be a lot more data coming on this in upcoming years. So this diagram I like because it really just makes it simple. We eat food. The bacteria break down the food that we eat. The food that we eat is then converted into a host of other compounds that are then used to communicate to various parts of the body, specifically to the hypothalamus in the brain. There's a part of the hypothalamus called the arcuate nucleus where information is integrated, and this affects our human behavior. It affects our eating behavior, it affects our drug taking behavior, and this is really, really important stuff. So the Ireland group has done some amazing research with the microbiome and really making it clear that a lot of the things that we would never assume are linked to gut bacteria are in fact linked to gut bacteria. So not just food, but drugs of abuse, also medication. So we're going to talk a little bit about medications and gut toward the end, but that's a really, really hot topic that I've become interested in. So right now I'm going to review my latest paper about the opioid crisis and present to you a conceptual model. This is an effort of mine to merge social and biological sciences. You can see I've color-coded the purple as social factors. At the top, we're thinking about the environment that we live in and socioeconomic status and the cultural norms between them. And toward the bottom in the kind of bluer color, we've got the biological factors, so the reward pathways. And the outcome here is not any specific health outcome, but it's just the consumption of substances. So I've lumped together food, drink, caffeine, nicotine, alcohol, and drugs. And you could see that anything that we eat affects the reward pathways, and there's an addiction cycle leading from reward to negative affect to the craving cascade and kind of reduplicating the consumption behavior. In the orange is some of the mediating factors. So if you think about SES at the top leading to psychosocial adversity, stress, trauma, etc., that can essentially affect brain reward, and I'll review some of that data. And more interestingly, we've learned, more recently I'll say, that stress and trauma can affect the microbiome. It can also affect the way that genes are expressed. And so this diagram is an effort to try to just conceptualize everything that's going on. I know that there's more going on, but again, it is important to not just think in terms of biology or sociology, but to think about it all as a comprehensive system. So there's 3 interacting perspectives, as I just summarized, in the biopsychosocial model for opioid. It looks at not only these environmental, psychosocial, and biological factors, but some of the moderating and mediating factors as well. And, like I said, we're looking at substance consumption, anything that affects reward, affects, behavior, and alcohol and drugs are most known for their effect on the dopamine system, but obviously caffeine and nicotine are highly addictive as well. What's less known is how, food and beverages affect reward, and that kind of falls under the umbrella of food addiction, which, like I said before, I'm aware is quite controversial. In public health, we always look at SES. Any model that we create is always looking at upstream social determinants. Typically, SES is measured by education or income or occupation. There are some forms of indices that combine these different things. And, with socioeconomic status, there's so many different pathways from there. So, for example, people that look at the social determinants of health will challenge the brain disease of addiction and really think about how someone who lives in a socially isolated place or certain neighborhood characteristics, fundamental causes of health, structural racism, etc. And considering how these social factors get underneath the skin is a big part of the Nancy Krieger research that I showed you earlier. So as a public health professional, we're always interested in the social determinants of health, and no model will ever go without considering social factors. The bigger question, in my opinion, is where does all the pain come from in the first place? Why do people need to medicate so much? And what makes people more susceptible to needing medication at the self level? And what makes people more vulnerable to becoming addicted? And this is where early life adversity and childhood maltreatment come into the picture. So why is it that 2 people that are exposed to the same level of adversity could lead to one person having profound biological alterations in the way they process reward, they're more sensitive to threats, and they have a heightened risk of a psychiatric disorder, whereas someone else might be way more resilient and have a much lower risk. So when looking at life course outcomes of early life adversity to later life health, we always have to think about vulnerability and susceptibility as well as resilience. This particular review came from Biological Psychiatry, which is one of my favorite journals. It looks at this life course approach to understanding resilience. So SES drives stress, trauma, and ACEs. ACEs are adverse childhood experiences. But of course, one could be stressed or traumatized or exposed to ACEs, from a high SES family or community, etc. So PTSD is a hot topic. I do want to point out that there's a difference between PTSD and complex trauma. PTSD is typically understood as an event that one can identify, where a lot of people have trauma symptoms without having any identifiable event, and that is often referred to as complex trauma, which is not an official diagnosis. So PTSD leads to increased risk for drug addiction, particularly with opioids. And this is consistent with the self-medication hypothesis. People with PTSD have deficits in reward functioning and increased levels of impulsivity. It has been suggested that trauma doesn't always lead to PTSD, but oftentimes when it does, it creates a condition we know as anhedonia, where there just isn't a lot of motivation, and this can create a high risk for substance use disorder. Substance use disorder can certainly be traumatizing, and it creates people in this cycle, which essentially affects the dopamine system over time and leaves people depressed and hopefully seeking treatment. The trauma theory looks at social and environmental factors. It looks at how painful life experiences alter the physiology and create higher susceptibility to addiction. The question is will improving social factors be enough, right? Can we just improve family systems and that will decrease addiction, or do we have to think about it more at the neurobiological level? The ACE research has really blown up. The first study was in 1998. It was from a large managed care. It was actually a Kaiser in San Diego. And they were able to show from a large data set that people that had 4 or more ACEs had tenfold increased risk of ever injecting drugs. So the ACE study has really birthed a lot of other research looking at how does ACEs affect cardiovascular outcomes, and now I'm interested in how do ACEs affect mental health outcomes. We know that early life adversity affects neurodevelopment, and as a dietitian and researcher interested in drug addiction and eating disorders, neurodevelopment is a key predictor of those behavioral health outcomes. Anything that affects, reward is going to affect substance consumption. So I want to just make that point clear. Anything that affects dopamine is going to affect substance consumption behavior. So to summarize, the biological embedding of adversity is a hot topic, and it's where a lot of my efforts are heading. We know from several studies, not just single studies, that with trauma, the hippocampal volume can be decreased. And this is a part of the brain associated with memory. We know that the amygdala volume can increase, although I will say that a recent systematic review meta-analysis suggested that the hippocampal reduction data was stronger than the amygdala increase data. We know that the autonomic nervous system is impacted. The HPA axis, which is responsible for the output of cortisol. We're not going to talk too much about that today, but we also know that trauma can affect the way genes are expressed. So for example, what types of adversity, whether it be sexual abuse, physical abuse, can affect how certain genes are turned on or turned off, and what are some of the critical or sensitive periods when that seems to matter more. So for example, does trauma at age 5 differ from trauma at age 12? And the answer is invariably yes, but do we know all the pathways and mechanisms? Not yet. The HPA axis is confusing because you're dealing with multiple parts of the body, you're really starting in the brain, and then stimulating the pituitary to kick in the adrenals, which outputs the glucocorticoids, which we have determined as cortisol in humans. So early life stress doesn't just affect the HPA axis, it also affects inflammation. And this is where I'm very much interested. That low-grade peripheral systemic inflammation, how over time, over many, many years, can actually affect the way the brain registers threats and increase one's risk for behaviors such as dysfunctional eating, drugs, high-risk sex, etc. And this is mediated through the reward pathways. We also know that stress can affect the gut, and I think this area is going to get much more attention in upcoming years. This particular image came from a paper from an alcohol model. We also know that obviously, what we eat has a similar effect on the gut to stress, and there's probably some debate around how important nutrition is in terms of being causal. In other words, why is it that some people can eat, a certain way and not have some of the negative impacts, and other people that eat, more westernized foods have really heightened negative effects? What are the differentiating factors? Why is it that someone could eat no vegetables in their life and thrive, and someone else could really need to put a lot more attention toward their nutrition? What are some of the genetic factors and the stress interacting factors that really make nutrition an individual and personal experience? So there's a lot of pathways in which adversity is biologically embedded. Allostatic load is a research measure of different markers of inflammation. As a life course researcher, I'm interested in how these things accumulate over time. There's multiple other body systems that are involved. We talked epigenetics for just a second, and I want to make one key point. The best evidence that we have for epigenetic modification, which is DNA methylation, occurs at the glucocorticoid receptor, and that is often referred to as NR3C1. That's the particular site where the glucocorticoid receptor is methylated, and this can affect the HPA axis and the stress response. And we have some data to suggest that this isn't always easily reversible. So trauma can be a very significant predictor of health outcomes, even when there's treatment and resilience factors, high social class, etc. It's not always redeemable by subsequent experience. Recent data shows that psychosocial stress affects the dopamine system. Specifically, it was shown that long-term exposure to adversity was associated with a dampened striatal dopamine function. And you could see here from the graph there is a significant difference. So a key point, stress affects dopamine. Anything that affects dopamine is going to affect substance consumption. I don't want to spend too much time talking about genes because there is some controversy. However, there is a pretty wide consensus that receptor dysfunction at the dopamine D2 site is a very strong predictor of addiction. I think what's probably more relevant to the human experience is to match genetic vulnerability and the psychosocial vulnerability, and to build models that look at the interactions and potential mediators there. The whole point of building conceptual models is so that we can identify targets for interventions. If you think back to my conceptual framework, you know, microbiome is a mediator between, you know, social and psychosocial factors and consumption behaviors. How can we step in? How can we get involved at the gut? Maybe more specifically with respect to the substance use disorder population, how can we educate people about this so that they can get involved in their nutrition and their gut health? We know that people that use opioids eat low fiber diets. Typically it's easily digestible foods like ice cream and cereal, etc. We know that people have constipation while using and typically have diarrhea when they get sober, or some combination of the two. We know that when people are using opioids, sometimes the constipation is 10 days, 2 weeks. Think about the possibility for certain bacteria to grow in a slowed down GI tract. There was some data to suggest one strain was increased 100-fold, and this was in a morphine model of animals. Interestingly, it's been shown that the gut microbiota mediates reward, and this is what kind of brings us back to this model. How do gut bacteria help the pain pathways communicate from the gut and the brain? This particular paper from my colleagues at UCLA actually won an award. And there's a couple other constructs in my model, NEUROECONOMICS, which is a pretty cool emerging area, which basically looks at, you know, behavioral economics plus neuroscience. There's a lot of neuroimaging data, constructs such as delayed discounting, which essentially looks at one's preference for a smaller immediate reward relative to a larger delayed one. This is closely related to impulsivity. So yes, gut bacteria and epigenetic patterns is starting to merge. A lot of this data is in obesity. I did my first systematic review and meta-analysis, which is currently under review, which linked ACE scores to adult obesity. So this is a meta-analysis of cross-sectional studies which link adversity in the first 18 years to BMI later on. You could see here that the pooled odds ratio is 1.46. So among all the studies that we combined, there is a 46% increase in the odds of adult obesity following multiple ACEs. So this is the kind of conceptual model that I've been suggesting here? How does early life stress, trauma, and adversity become biologically embedded? How does that create addiction-like behaviors? And how might that lead to weight outcomes? Of course, this model is incomplete because it could also lead to eating disorders, which are often associated with dietary restraint and weight reduction. Although I've simplified it here, and there is research happening in this area. From UCLA, for example, it has been shown that those that have been exposed to early life adversity might have higher food addiction behaviors, and this, is certainly more challenging in the food environment that we live in, where there's highly processed foods everywhere. So, if you think about it, if someone's been exposed to trauma and their reward system has been altered, and then the food environment is set up so that there's nothing but highly palatable foods, it's almost unrealistic to expect someone to thrive as an eater. And it makes sense why people go to drastic measures such as extreme diets and end up with eating disorders. And so my public health hat is starting to wonder, what can we do to intervene on the food environment? How can we help reduce people's exposure to trauma? What can we do upstream that will essentially affect outcomes downstream? So people have said it forever, when you eat better, you feel better. When you eat, more whole foods, you have improvements in wellness. But as I was saying before, why is this impact so much more pronounced in some people than others? Why does nutrition matter so much for one person and doesn't seem to matter for someone else? And more importantly, what are the mechanisms that are linking what we eat to our mood for certain people? We're starting to know these mechanisms, right? It's the gut bacteria. We also know that many of the highly processed foods have certain ingredients that affect our gut bacteria, which over time can affect our mental health. Big question is, how do medications impact the gut? And I'll review a couple studies, but this is a hot topic. There's at least a dozen papers now that have shown that medications have varied impacts on the gut. Obviously, opioids have been studied, reducing digestive processes. There's data to show that opioids modulate the host immune system and cause microbiome alterations. There's a lot of antipsychotics that are also affecting gut microbiome. Antidepressants have been shown to reduce richness and increase the beta diversity, so essentially affecting the range of species that exist in both animals and humans. This particular study was on humans, again from the Ireland group, showing that these SSRIs, antidepressants, can increase permeability at parts of the ileum, and that other drugs might reduce bacterial diversity, but these two factors are not causally linked. So really important papers to read if you deal with patients or clients that are on a lot of medications. It might explain why people have weight changes with respect to medications. It's not always just simply changes in eating behavior. So we have to think about biology. A calorie is not a calorie. It is about the food. Psychological interventions are not sufficient. We can't just talk people through it. We need an intervention, and I think we need a public health intervention. I think the Western diet's a part of the problem. It's too low in fiber. It's too high in sugar and artificial sweeteners, which we didn't talk about today, but I think it's probably pretty well understood that artificial sweeteners have profound negative impacts on gut bacteria. We also didn't talk much about fats today, omega-3 versus omega-6, but the Western diet is known to be high in inflammatory fats. So the solution from a nutrition standpoint is the opposite of that. It's a diet that's high in fiber, low in sugar, no artificial sweeteners, and much higher in the anti-inflammatory omega-3 fats. It has been shown that supplementation with omega-3 can reduce opioid seeking, and this was in an animal model. I think there was a human component as well, or at least there's one underway. I don't think that's been published yet, but yes, there is some evidence that anti-inflammatory omega-3s in an animal model can reduce the amount of opioid seeking. This is just really, really groundbreaking stuff. So when we're dealing with our clients, we want to get them eating more omega-3. The best source, as you hopefully know, is from fish. However, not everyone eats fish, so we can use plant sources, flax seeds, walnuts. I'm a huge fan of chia seeds. My major area of interest, as I mentioned, is fiber. We want to get people to reintroduce fiber, especially if they're coming off of drug addiction. If someone hasn't been eating a lot of fiber, they're not going to be able to tolerate it very well. So we need to move slow, one baby carrot at a time. Focus on improving gut health and, getting people to understand why we're doing this. It's not just for vitamins and minerals. We're actually changing our food so we can change our internal ecosystem, which can really affect our mental health over the life course. I'm a believer in getting fiber from foods, not from supplements. So a whole range of plant-based foods, getting cooked as well as raw. I try to encourage a fruit or vegetable with every single meal or snack. One of the reasons that fiber supplements don't have the same effect as fiber from food is because food fiber has polyphenols in them, which turns out are strongly preferred by microbes as well, and there's a synergism between the polyphenols and the fiber. So there's a bunch of really important polyphenols that are being shown to reduce neuroinflammation and are really important parts of the gut-based nutrition interventions. There's other fermented foods out there, whether it be dairy or dairy alternatives. Fermented vegetables. I think cabbage is the most popular, sauerkraut, kimchi, things that I am a fan of. We have data to suggest that probiotics has been associated with significant reductions in depressions. I think there's probably 3 or 4 systematic review meta-analysis at this point that have shown that, yes, probiotics can reduce depression. This does make sense for someone in early recovery. I do believe that timing matters as well. I sometimes give someone the mantra, never hungry, never full. Just reduce extremes. Try to eat on a regular and consistent basis. Sometimes getting people on an eating pattern where you eat within 30 minutes of waking up and just kind of eat regularly throughout the day is got profound effects on their behavior. I did publish guidelines for nutrition in addiction recovery. Here are overall recommendations for recovery from all substance use disorders. Lots of recommendations here that are, mostly generated from published studies as well as some of my own clinical experience. I have specific recommendations for opioids, and in the chapter, not so much here, there's more information about stimulants and other drugs, including alcohol. There's certainly areas where we need more information. You could see here I've made a list of targets for future research. And so with respect to opioid treatment, we need to think about, severity. We have to think about trauma. We have to think about trauma interventions. We have to think about the brain. We have to think about nutraceutical as well as nutritional gut-based interventions in order to really treat someone at the biopsychosocial level. Of course, thinking about food simplistically is problematic. I call it dichotomania. Thinking about food as either being good or bad, right? That's not a helpful way to think about these things. We often call it a cognitive distortion. However, when it comes to mental health, we can start thinking about gut healing versus gut harming, right? If something has the potential to promote dysbiosis and imbalance in the gut, how can we promote that for a mental health client? Of course, with eating disorders, there are certain behaviors that we have to watch for: skipping meals, dieting, lots of charge around food, leaving the table right after eating, laxative teas, weight loss supplements, hiding food, playing with food, talking about food, body a lot, and also what people follow on their social media. So the big picture goals are typically not weight focused. That is not what this is about. This is about recovery, focusing on overall health, helping people develop self-efficacy, helping people gain access to sanity. And recovery is a different thing from person to person, but eventually we want to help people develop a relationship with food and exercise that is intuitive and personal, avoiding the quick fix whenever possible. Last year, we presented this information at the International Society of Nutritional Psychiatry Research. This is a photo of myself and colleagues from the NIH, and we were able to present some of the latest data on nutrition for drug and alcohol treatment. So I share this because I want you to know that the movement is happening. There is momentum. We are making a change. In conclusion, I think it's really important to know, and this is a quote from a professor at UCLA who recently passed away, so rest in peace. Exclusively gathering data from a single theoretical perspective makes it impossible to evaluate the validity of the theory being tested against other theoretical perspectives. The omission of variables that operationalize competing theories from the analysis may lead to misleading results. That's why I think we really need more variables from other disciplines. You know, what if the skill we needed was better assessment and better discernment? And what if this biopsychosocial model was the key to success in dietetics? People ask me all the time, Dave, what's your food philosophy? They want to know. They want the summary statement. They want me to be able to recap it in just a sentence. And I'll tell you, I don't have one. I have many skills. I have a lot of different things that I do nutritionally with people. In one case, I teach people how to include more things. In other cases, if there's trauma and addiction, I might teach people something else. We need to be discerning and be able to help people navigate the tricky terrain of food. If all you have is a hammer, guess what? Everything starts to look like a nail. So dietitians, mental health professionals, eating disorder professionals, it's time to diversify your toolkit. We see what we see on the surface. We see the branches, we see the leaves, we see the grass, we see the trunk, but there's so much going on underneath. We call that the root of the problem. As a public health professional, I am interested in the root, but I've also become interested in the soil, which is the entire social context. We need to think about it all in order to be most effective as thinkers and as treatment providers. And lastly, food for thought is no substitute for the real thing. Thank you guys for your attention. If you have questions, feedback, you want to get in touch with me, you can send me an email, follow me on Instagram. I've got content every single day. Would love to connect with other professionals. During this quarantine crisis, I am doing telehealth and have been able to connect with people from all over the world. Until then,